Thank you guys to my Sunday morning diehards for hanging out. I promise to keep this light and informative. I don't see Stan, Dr. Goldvac in the audience. So Stan actually got to steal my talk, Analgesics of the Future, which is certainly a much more exciting topic than what's new. So that what they asked me to do is just tell you what's new in the last year or two on the face of pain management. For those of you I haven't met, I'm Jeff Gudin, trained in academia, recently just sold my practice up north and am moving with the family to Palm Beach in about a month. Got the kids in school and as Dr. De La Garza said, probably snowbird back north for a year or two and then hopefully be your neighbors here in Florida. Maintaining my activity in research and publications, I am sought after by most, if not all, of the companies that make analgesics. Hence, if you see my disclosures on the screen, I've either done research, speaking, consulting, publishing, or other activities, including representing many companies at FDA with novel analgesics, including many of the abuse deterrent formulations. So I have a close relationship with industry. I try to keep them at arm's length. Let's face it, without industry, we couldn't advance any new molecules forward. And I'll mention just briefly, even though I won't step on Dr. Goldvac's toes, some of the things that are in development, which are a little bit more exciting than what we've had in recent years. So the excitement in development, obviously, unless you've been in the closet or haven't walked around the exhibit hall, cannabinoids are a really big thing now. I'm still not totally convinced of their analgesic potential. I know we could debate that for the next couple of hours. I think we've yet to find the right dose, the right combination, the right derivative of CBD, and we're just in the elementary phases. I'm looking forward to the day that we have a cannabinoid agonist that lacks the psychoactive properties, so we don't even have to think about it, and we would just write it as a typical analgesic. You probably have seen NGF in the news, especially if you read the Wall Street Journal or the New York Times. There's a number of companies that have NGF antagonist, nerve growth factor antagonists. They are very close to launching. They've been in development for the last few years. Very powerful central and peripheral anti-inflammatory agents. But unfortunately have had some evidence of early joint destruction in patients with advanced OA that they're trying to work out what are the right doses and who should get these medicines. Sodium channel blockers are still on the horizon, still being worked on. Gene therapies is just such an exciting area of research. And we hear about pharmacogenetics, but rest assured in 10 years from now, this talk is going to be much different. It's how do you test your patients to determine what's the best analgesic for them, right? Personalized medicine, and that's where we're going. I'm developing a talk on that, but we're not even close enough there yet to talk about those things. I'll mention some of the novel opioid compounds in development. We can't throw the baby out with the bathwater. There are ways to create opioids that don't have respiratory depression and don't have the euphoric or high associated with them. So if I told you we had an opioid that lacked any other side effects, you would say, hey, who cares what it's called? I want it for my patients. And then I'll talk a little bit about opioid receptor antagonists. Just to mention a couple of the agents that are in development, you see here biased agonists. Not to get too deep into pharmacology on a Sunday morning, but when an opioid binds to the receptor, there's a lot of cascades that happen. So you guys probably remember the opioid receptor is a G protein coupled receptor. Once you bind, there's all these downstream signaling events. They think that if you could preferentially activate certain of those downstream pathways without all of them, you can get agonism, analgesia, without respiratory depression, nausea, some of the other side effects. So you may have seen in development one of these molecules here called oliceridine by a company called Trevena. The results are promising, but not all that exciting. I mentioned it here because there are other biased opioid agonist in development. Some of you may know of the street drug metrogynine, metrogenine, or kratom, as they're calling it. You can buy it in head shops in many states around the country. Metrogynine is purported to be one of these biased agonists, and it may actually have a medicinal role, believe it or not, kratom, but it's got to be studied in the right way and not over the counter in head shops. You'll see on here DANK inhibitors. It turns out you're all familiar with opioids, and they bind to the mu opioid receptor, but remember we have delta opioid receptors, right? And that's not our endorphin system, that's our enkephalin system. We have kappa opioid receptors, and these other opioid systems play a role in analgesia. So it turns out there's a couple of products in development that have focused on the delta opioid receptor. It might not just be an analgesic, it might be an anxiety or a psych drug, right? Like a rescue psych drug. So they've found ways to modulate the delta opioid system through these DANK inhibitors. Novel slow entry opioids. There's one I was supposed to go to FDA for in August. They just delayed the meeting. This is an opioid that they put a big long side chain on, pegylation. You probably remember one of the constipation drugs is a pegylated naloxone or naltrexone, right? So it doesn't get through the blood-brain barrier. This is the same concept. It gets through, it just takes a really long time. So I use the same bad joke all the time. If you want to be high on Friday, you got to take the drug on Tuesday, right? Not the most attractive of opioids. It has its downsides. You could still overdose. There are plenty of, it's a mu opioid, but it's a slow entry opioid into the CNS. So a lot of promising research on that front. There's gene therapies that are out there, and I'm not going to spend a lot of time on these. Abuse deterrent opioid formulations have a lot of promise. They are the minority of opioids written nowadays. There are a few more of these in development. There are some short-acting ones that have been approved, like an oxycodone abuse deterrent formulation. I went to FDA late last year. One of the generic companies, actually the generic company that makes oxycodone, roxicodone, went to the FDA and said, hey, we want to seamlessly replace all of our oxycodone. We have a big percentage of the market, generics and branded. We want to seamlessly replace, not even tell anybody, oxycodone with an abuse deterrent oxycodone. And here's what they did. They put the active ingredient from Sour Patch Kids, tartaric acid, into oxycodone, and when you snort it, it hurts like hell. In a blinded abuse liability study, the recreational abusers said they would rather snort placebo than snort this, right? You don't want to snort something that hurts. And the FDA turned them down for a variety of political reasons, or whatever. But we might see that, right? And they weren't going to market it. It wasn't going to be branded. They were just going to replace all of the oxycodone. So we have some of these cool technologies on the way. We need to adopt more of them if you're still using opioids for ADFs. Okay, so to the bulk of my presentation, what's new in the last couple of years? Well, not a whole lot. Just so you know, you're going to see these things coming through the doors of your office. By the way, you guys, I don't see a timer up here, so you got to give me some heads up. So some of these you actually saw in the exhibit hall, and that's pure. I didn't change my talk at all. It's purely by coincidence. What's new and approved in the last couple of years. So I'll take you through these in a rather rapid-fire succession, just so you've heard about them. Lofexidine. So you're all familiar with the use of clonidine, an alpha-2 agonist to treat withdrawal symptoms. We probably have all used it at some point in our careers. I directed an addiction treatment center, and it was at the heart of. Oh, I'm not tall enough. Thanks. Now I see it there. Thank you. It was at the heart of our treatment plan. Every patient in the ambulatory detox program got clonidine. So a company called US WorldMeds took this drug that's being used around the world called Lofexidine. It is another alpha-2 agonist. So if you know a little bit about clonidine, you'll know a little bit about Lofexidine. I put the trade names in here. Even though this is a CME talk, these are specific products. So not for better or for worse, but just so you see the trade names here as well. It got approval last year for the mitigation of opioid withdrawal symptoms to facilitate abrupt opioid discontinuation. It does not have approval to use during tapering, which is what 99% of us have spent our time doing in the last year or two, since CDC guidelines, payers have forced us to get down to 90 milliequivalents or less, which is kind of a travesty because for those of us in the room as pain specialists, those guidelines aren't meant for us anyway. And they weren't meant to be payer policies, but even CMS has adopted these numbers. I won't say any more about that. So if you know a little bit about clonidine, you'll know a little bit about Lofexidine. It's alpha-2. It has an anticipated cardiovascular side effect profile. It did a number of studies where they looked at withdrawal scores and whether the clients or patients could actually stay in the study because withdrawal gets really uncomfortable. And so they measured time to dropout. And those data, as well as a long-term open-label safety study, supported the approval of this drug. It's 3 tablets. They're in micrograms or 0.18 milligrams. You take them 4 times a day. I've used this if patients aren't tolerating it for hypotension or they're just feeling junky. I have them skip a dose, and I even think the label supports that. And believe it or not, you can get withdrawal from this drug. So you can't just stop this drug to add to the complexity. You need to taper this drug over a couple of days. And as you would expect, you need to carefully select your population. Younger, healthier patients going through withdrawal tend to tolerate this. Older patients with cardiovascular disease, you really need to be careful because you can get hypotension and bradycardia. Okay, following our last military symposium, this is a drug that was approved by the FDA, supported by the Department of Defense. As any of you who work in a hospital setting know, we've had some opioid shortages in the last couple of years, and we've been really maximizing our regional anesthetic and our local anesthetic techniques and our ERAS protocols and our opioid-sparing techniques. This is a sufentanil nanotab. It's a sublingual formulation. If you look at the picture on the left here, it's kind of hidden. That's what the delivery device looks like. If you saw the news after this thing was approved, people said, "How could you approve this, another fentanyl-like drug? Are you crazy?" This is a drug that's kept under lock and key only for use in a hospital or medical setting. This is not an outpatient drug. This is not a drug that people will be easily able to get their hands on. But it is kind of useful in the peri-op or perhaps in the military setting where you need rapid onset of opioid analgesia for acute pain. It's 30 micrograms. I remember back in the anesthesia days, we used to use sufentanil for cardiac anesthesia and for some other cases. It's a very potent drug. It's delivered by this little applicator. Sublingually, you need a minimum of an hour between doses. And I just put the PK curves up just so you could see. If you gave IV sufentanil, you'd reach a very big peak plasma concentration. Bioavailability is 100%. You get it all immediately. You can get respiratory depression and somnolence and all the other opioid side effects. When you give it sublingually, you kind of flatten out the curve a little bit, and you get this relatively safe profile, obviously only in monitored healthcare settings should this drug even be considered, just to know that it's around. I put this in here not because it's an analgesic, but because everybody asks about it. Hey, did you hear they just approved a nasal ketamine? It's called Spravato. It's by Johnson & Johnson. It's S-ketamine. If you remember, many of the drugs we use are racemic enantiomers, right? They have mirror images of each other, so S and R are dextro and levo. This is just the S version, so they called it S-ketamine. It's a Schedule III drug indicated for treatment-resistant depression in conjunction with an antidepressant. To my knowledge, it has no approval or it hasn't been studied in any pain conditions. We are huge fans of ketamine. I have a guy down the block who made a practice out of ketamine infusions. I've sent a lot of patients for them, but as far as I know, no one's really using this formulation. There's a REMS program with it, so you need to register with the REMS and follow all the guidelines that go along with it. For the treatment-resistant depression patients, it did meet its endpoints. It seemed to be efficacious, but if you look, 50 to 60% had sedation, and it could be prolonged sedation, so they have to be kept in a monitored setting as well. So don't go home and use nasal ketamine in your outpatient pain patients. This you saw next door, and I actually, just for full disclosure, was instrumental in getting this drug FDA approved. It is a newer, thinner, lighter, and much more adhesive lidocaine patch. It's called ZT Lido. It's 1.8% patch. If you remember, we have a 5% lidoderm patch. I don't know, I used a fair amount of lidoderm and also Flector, the diclofenac patches. Adhesion, Flector more than lidoderm, but adhesion is an issue. You look at these patches, they're all bunched up and curled up, and they go on wet and goopy. This company was able to form a very thin patch. It's a spray-on drug in adhesive. The patch contours nicely to curved areas. It's very adhesive, and it has, I don't know, somebody do the math, 1/20th of the amount of lidocaine. So the lidocaine patch, original, 5%, 700 milligrams of lidocaine. So 700 milligrams at 5% delivered about 35 milligrams of lidocaine or so. These guys got bioequivalence. I think I put the curve here. This is their 1.8% versus the 5% patch. They got bioequivalence with 36 milligrams of lidocaine in the patch, not 700. So not that this is fentanyl and there's that much of risk to external exposure, but it's a lot less drug, a more efficient delivery system, and I think you'll see it around. All right, we're doing good on time. Everybody okay with the pace? I know it's Sunday morning, but good. All right, New York pace. Naloxone formulations. There's been a lot about naloxone in the news. What our first responders were using for years and years was this little, home atomizer kit where we simply put naloxone in a syringe, spray it up the nose, and wait for the absorption to happen. Many of you saw the next generation auto-injector, which I've also consulted for them and done a bit of research and writing. The challenge is the cost. Right? It's a really fancy device, very novel. If you've ever seen the inside technologies, it's truly amazing, and it could justify more cost than a nasal atomizer. But cost was definitely an issue. I just heard that there's a generic version coming by a subsidiary of the original manufacturer, so that we should have better access to the auto-injector. Hopefully most of you know that also this year approved was a nasal naloxone device. It looks a lot like your Imitrex migraine delivery system, the intranasal device. And not sure if you saw the news, but just last Saturday, a patient on Delta Airlines overdosed injecting heroin in the bathroom on the plane. They had to break the door down, and they were not able to revive him. Died on the plane. So in the news, Delta announced that they're going to put naloxone in its airline kits, the same way many others have. By the way, once naloxone started to become popular, I went to our ORs, I got a vial and a TB syringe, and I carried it in my briefcase. I haven't had any chance to use it, but I carried it around just in case. By the way, also, many of you might know my evil twin brother, Dr. Jeffrey Gudin, with an F. He's a pharmacist, very famous pain researcher in upstate New York. He's worked on an app where you can geolocate a person who has, so if you're a naloxone carrier, you can go on and find somebody. So if you're in an emergency, you go on the app. I mean, who's going to think to do that? But you go on the app and you can find the nearest person with naloxone. Kind of cool, using technology for medicine. FDA really supports this. If you noticed from HHS, which included the task force that some other speakers have mentioned, they talk about using better reversal drugs, and there's a generic naloxone nasal spray coming. And I just chatted with Dr. Danjal after his last talk. I'm going to skip over. You probably know why we need to co-prescribe naloxone. Just so you know, technology and medicine are marrying each other more and more. There are